Hello, nice to meet you all. In today's video, we will be discussing the effects of bipolar type 1 disorder and how it specifically relates to our patient. We will be using the analogy of weather, as much like bipolar disorder, it is unpredictable. It does, however, fall on a spectrum where it ranges from manic to depressive, much like our emotions. So hopefully by the end of this video, you will be able to see the similarities between the two and develop a better understanding of bipolar type 1 disorder.
Our patient was brought to the hospital following an incident on the 25th floor of a hotel where he was with his case manager and was growing increasingly psychotic due to a manic break secondary to medication noncompliance. He began to say that he was going to jump off the balcony of the hotel and that the people he talks to in the sky would catch him and lower him down so he could get away from, quote, those people, referring to his case manager. He was seeing prominent figures in the wall and believed that Donald Trump was present and that the patient had stolen Trump's soul and it needed to be returned. He has significantly poor insight to his illness and often bribes staff members with substantial bribes to, quote, get him out of the loony bin. He does not believe that he is ill, but rather that he was admitted to the psychiatric facility because his recent ex-wife, whom he described as a cheating Chinese concubine, had taken over his mind and turned him in.
What is he doing? He's spinning, isn't he?
Felix has just gone supersonic, but he's lost control.
Our patient has a history of psychiatric hospitalizations in California due to suicidal ideations and attempt, including one as a child. He reports poor family support and used cocaine, alcohol, and nicotine for 15 years. He is currently in rehab for cocaine use, and this was supported by a negative urine drug screen. We spoke with a 38-year-old Korean-American male. He is a successful, self-employed music producer with ample funds to create a lavish lifestyle for himself. He has no children, is recently divorced, has a poor relationship with his mother and sister, and a fairly decent one with his father. He owns homes in both California and Oahu, and recently moved to Oahu 6 months ago on an unsuccessful honeymoon whim. He is a self-described musical god with a 15-year cocaine, alcohol, and nicotine addiction, for which he has been receiving treatment for 6 months with the help of a private in-home rehab and mental health treatment team. He had recently stopped taking his psychiatric medication, resulting in a psychotic manic episode related to bipolar 1 disorder, and is being held on an MH4.
And now let's talk about mania. Mania is a byproduct of bipolar disorder and is characterized as having a distinct period of abnormally and persistently elevated, expansive, or irritable mood. This is accompanied with high energy and activity that lasts at least 1 week and occurs most of the day, or if not, nearly every day. This disorder can get so severe that it usually requires hospitalization. So it's important to note that this disorder consists of the verbiage abnormally and persistently, meaning this is not the case where one might feel off for a couple of days and return back to normal. No. This is behavior that is way over the top and is noticed by multiple people. Abnormal is a common term used to describe this, but really it just is a behavior that stands out in a negative way. According to the DSM, to be diagnosed with bipolar disorder type 1, you need to display 3 or more of the following symptoms while displaying severe behavioral changes. As seen with our patient, he displays multiple characteristics fitting the description of being manic. These symptoms included inflated self-esteem or grandiosity, where he felt superior to others and felt that he did not belong.
Oh, what a day! What a lovely day!
He also displayed a decreased need for sleep and restlessness, and increased talkativeness and racing thoughts where the patient discussed multiple topics with the nurse with no correlation. Distractibility, where he went into song breaks at random time and not paid attention to any of his surrounding. An increase in goal-directed activity. Agitation, engaging in activities that hold the potential for painful consequences, such as impulsivity, where he tried to bribe multiple staff members with ludicrous amounts of money to let him go. All of these symptoms were positive for our patient. He displayed every single one of them. The patient also denied any of these symptoms as he claimed that he was okay.
Aside from having at least one manic episode to be diagnosed with bipolar 1 disorder, major depressive disorder may also occur. Depression and the agitated state of mania is a dangerous combination that can lead to extreme behaviors like violence or attempted suicide. Depressive symptoms include having intense sadness or despair, lack of energy, loss of pleasure, and lack of interest in activities, difficulty concentrating, loss or increase in appetite or sleep, tearfulness, restlessness, and self-destructive behaviors including suicidal ideation. Hospitalization may be required if suicidal ideation, psychosis, or catatonia is present. A major depressive episode is a period of at least 2 weeks in which a person has at least 5 of the symptoms mentioned earlier. Our patient's admission was precipitated by a suicide attempt. He is self-destructive as he responds to internal stimuli. He harmed himself by hitting his head several times to remove the voices in his head, and recently almost jumped off the balcony. He also reported difficulty sleeping and was easily distracted. He has a complicated relationship with his family by describing it as fair relationship with my father and poor relationship with my mother. Patient has history of depression and he has past history of suicide attempts, including one as a child. We use 3 standardized assessment tools to help assess our patient. The first one is the Goldberg Mania Scale. This is an 18-question screening test for mania. The patient got a score of 80, indicating severely manic. The second scale we use is the TM33 Suicide Self-Harm Assessment. This measures current suicidal ideation, including plans, intensity, lethality, as well as past history attempts. The patient got a score of 20, indicating very high risk for suicide. The third scale we use is the Global Assessment of Functioning Scale. This is used to assess how well the patient is functioning in his daily life. The patient got a score of 30, 21, indicating that his behavior is considerably influenced by delusions and hallucinations with impairment in communication. He is sometimes incoherent and acts inappropriate with suicidal ideation.
Good afternoon, guys. So my name is Kate. I'm the charge nurse. So we're gonna talk about our patient who is 39-year-old male who is involuntary hospitalized yesterday due to psychosis secondary to a manic episode of bipolar 1 disorder. So I guess we're gonna talk about if he's ready for discharge. Doctor, what do you think?
Yeah, as his physician, I'm very concerned. He is non-compliant with his meds. He is scheduled to be taking lithium, risperidone, trazodone. When he was admitted, his levels were well below the maintenance level. I understanding he's still having delusions, paranoia, thoughts of suicide. I'm concerned of his safety and the public safety and him traveling on a plane. So tell me what you guys think.
Yeah, I mean, as a social worker, I can definitely agree with a lot of points you're saying. I'm concerned of like who he's staying with. Is he by himself? I know that he's from mainland, so I don't even know if any family members are here or who you can contact. I'm just worried about if we need to keep him here a little bit longer for 24 more hours just to see if he still has thoughts of suicide or anything related to that.
And I'm actually his mainland-based case manager, and I work for a company that has been contracted by this patient specifically to help him manage his mental illnesses. And he's really not that far off from baseline. I hear what you guys are saying, that he is delusional, that he is seeing things. But in general, this patient does present as a little erratic. and we have been working with him very closely to manage his medications. And while he doesn't have any support system here, he does have a friend who is willing to help him pack up. And I will be with him throughout the entire flight on the plane. I will medicate him appropriately. And getting him to the mainland where he does have the social support of a psychiatrist, a therapist, and a deeper circle of friends, I think is really in this patient's best interest.
Do you feel safe?
I feel like I can manage him appropriately. I have worked with him long enough to know his triggers and know when to get him out of a situation. I feel like he is able to recognize me as someone that he knows that has
Any
worked with him for a
violent
long time.
outburst on the floor recently, nurse?
Well, he is still persistent with his manic episodes, still has his delusions, hallucinations. So,
And again, I hear what you guys are saying, but he is not far from his baseline at this moment, and he is drastically improving from when he was admitted. I think another 24 hours to go with proper management and someone to accompany him 24/7 will result in a successful discharge for him.
I'm good with another 24 hours, and we will medicate him, and you know him better than anyone else.
Perfect. Thank you.
Thank you.
Good luck.
And now let's take a look at our resources. We have it divided into Hawaii, National, and California resources, all available that our patient can utilize. Patient outcomes. Patients will be free of dangerous levels of hyperactive motor behavior with the aid of medications. The patient's primary medication is lithium, and we want it to be a therapeutic value of 0.6 to 1.2 milliequivalents per liter. He takes one dose of this in the morning of 300 milligrams and one dose at night, 600 milligrams. We expect a therapeutic value to be reached within 2 to 4 weeks. Lithium is a mood stabilizer, as we want to see a decrease in acute manic episodes using Goldberg's mania scale of scores less than 2, as evidenced by decreased hyperactivity, pressured speech, and mood swings. Next, we will be looking at patients' desire to be free of self-directed injury by establishing social supports when feelings of destructive behavior occur. He can contact places like NAMI, Catalyst, and Passages, or also utilize friends and family too. We will be seeing an absence of suicidal ideation in the next 24 hours and a decrease the score of less than 3 using the TM33 depression scale. At the end of the day, bipolar disorder, if left untreated, can be detrimental to the individual and family relationships. Thus, we must continue to understand the individual and not form stigmas based on no evidence. With proper interventions, we can reduce such debilitating symptoms and help the person live a normal life. However, we must not forget that through disorders or different ways of thinking about the world, creativity can be fostered.